compared to other bones because awesome because they have lots of other points of fixation even without necessarily putting in bars and things like that. So there's lots of things that hold ribs in place. But we have a fair number of folks that slip through the cracks, and this is relatively new technology in terms of the materials that have developed over the last 15 years or so. And there's actually a lot of opportunity to help folks, and we're expanding the use of this in a way that I think everybody should be thinking about it more. So we should all be looking at these films and thinking about when we can help people with this technology. I don't have any COI in this field. So when it comes to thoracic trauma, as always, we start with ABCs, ATLS. In the Bay, the first thing that we need to be doing is getting a chest X-ray, EFAS to identify whether or not we have drop lungs, hemothoraces, and then thoracostomy, empty things out, thoracotomy for immediately fixable things. And looking at chest X-ray findings, I like to remind people in the Bay that not every density is a hemothorax. So, if your chest density is not obeying gravity, and we had one of these the other night, and the contusion is basically going to stay focused and localized, as opposed to something that has an air fluid level. That's more of a hemothorax versus your normal chest X-ray. Okay. Things about identifying tension. This is probably a little too basic for this group. One of the things I want people to focus on in the unit is that folks will come up with rib fractures and there'll be a little bit of air escaped outside of the chest, and this can be a subtle sign of tension when people have subcutaneous air. That is a sign that air is escaping from the lung and it's coming out with enough force to dissect tissues. And a little finding like this next to a rib fracture, a lot of times we'll say, oh, we're going to shoot a follow-up chest X-ray in 4 hours, but I'd like everybody to have like a higher degree of clinical suspicion for these, because if you have enough pressure coming out of the lung to dissect tissues, it's a sign that you have some element of tension physiology occurring. So this was a patient that initially showed up and just had this little spot of air next to, wasn't actually directly next to the rib fracture. Rib fractures will often cause a little bit of cavitation in the immediate area just because they've kind of dissected into a space that isn't used to existing, and you'll see like a few bubbles. But this type of thing I want people to look out for and be a little bit more interested in. It's away from the immediate rib fracture. It's a suggestion that dissection is happening. And then the follow-up chest X-ray showed that, which is more air. And now the patient's heart rate's going up. And it's just a simple rib fracture. Oh, it's just a little bit of air. Be alert, because subcutaneous air is sometimes a sign of tension. And now in the morning, and this is when we looked at the first picture and morning report, now there's a bunch of air in the chest. So this is a patient that is probably going to decompensate without a chest tube, and you need to attack these types of things. EFAS is a really good technique. It's pretty sensitive for pneumothorax. It's not going to necessarily pick up subcutaneous air, but it's something we're bringing up. But learning how to read this in chest trauma is actually useful. You're going to get a lot more ultrasound guidance from Enya when the time comes, and you're going to learn how to read these very carefully, and also always remember to make her happy to save the results, or else the ultrasound didn't happen. But pulmonary ultrasound is something that we can do at the bedside. You can do it in the unit. There's always an ultrasound that's available, and there's findings that are super useful to know about. So the B sign, basically seeing that there's a lot of fluid in the lungs. You're getting a lot of lines basically from the reflection back at the probe, versus just a single line. We're going to see that that's ordinary. That's a sign that you just have lung opposition and some reflection, maybe against a blood vessel reflecting back against the probe. When we're talking about identifying pneumothorax, you're mostly interested in the loss of any of that, those comet signs is what they're describing, and that fixed absence of lung sliding and movement along the plane, because generally with normal healthy lungs, you don't really see very much below the intercostals, and but you can see that pleura, and if that pleura isn't adequately sliding back and forth, if you don't see these kind of comet signs, that means that you're not seeing the normal lung behind the front line of sound going through the chest wall. So it can be a specific and immediately useful result. If you have any question, you can always put the ultrasound into M mode and look for whether or not there's motion. And then we talk about seeing the waves on the beach, which is normal and happy. But if there's no motion, it's just going to look like lines going back and forth or a barcode. Probably don't need to tell you guys much about tube thoracostomy or ED thoracotomy. And let's just jump right into rib fixation. So I want to go over the history of this because there is a long history of trying to do this, which is actually interesting and informs what we do now. Current systems that exist, the indications for it, which is really important, and the evidence basis is growing. The technique I'll talk about a little bit too, because I'm one of the rib platers, and I will probably work with some of you throughout the year in doing this. I think it's a valuable skill to learn because we're going to do it more, and I think it's probably become standard of care for us for a number of indications. So trauma surgeons need to start developing experience with it, or at least know when to refer. And then we'll talk about some cases. So, I wasn't joking, about 100 years, people have been trying to figure out a way to plate ribs. Initially, steel was used, and so plates were initially developed, even going back into the 1900s, to try to bring ribs together. Because when you have significant fractures and loss of architecture of the chest, it just makes sense that we should be operatively reducing these and putting things in position so the bones can find each other. However, the problem with steel has always been that steel fatigues, and the chest constantly moving results in the steel plates not being particularly durable, and they also don't have the strength of current titanium systems. So none of these techniques really significantly caught on or were significantly better than what became the standard of care, which was ultimately putting people on positive pressure, sometimes on the order of weeks, to expand their chest and allow the ribs to fix in place so that the chest didn't cave in. And a number of these systems were developed based on various different types of steel fixation. The most recent one was actually Kirschner wires, and you will still occasionally see, I've seen one Kirschner wire in a human, and they're still around. The problem with the Kirschner wires is that eventually they would erode through the bone, and sometimes they would end up sticking out the skin and you'd have to remove them. But generally the idea is like, we know how bones fix. Bones need to have opposing edges in order for them to have growth back to each other and to meet. And the edges need to meet for the bone to stop growing, otherwise you get heterotopic ossification. And some folks that have significantly displaced rib fractures, they end up with pathologic healing, and the bones will keep on growing, and if they don't meet something, they'll end up basically growing a spike. Less actually common in blunt rib fractures compared to rib fractures caused by bullets. And while there isn't really a great indication for using ORIF for bullet fragments, because it's usually just one or a couple of ribs, it's something to think about that when you have bone fragments that are floating around loosely in soft tissue, they'll tend to grow because the cells, that's just the way they've designed to or they've learned to fix fractures throughout evolutionary history, is that they grow until they meet other bone and stop, especially if there's movement. So lots of things have been tried. Plates and wires made of steel, wires and cerclage. These often required removal. They had breakage. They migrated. And again, steel strength is actually not that great compared to modern materials. And this is where titanium systems became involved. So titanium systems started to be implemented in the early 2000s, and they've gotten refined since, and have gotten a lot more easy to use and more approachable. So it used to be that we had these titanium systems that you had to wrap around the rib. They weren't super flexible. You had plates of specific lengths. And if you look at this like kind of clamp, we've seen patterns of rib fractures. Rib fractures, there's no two alike. So you're lucky if you have something that you can just bridge across like a fragment like this and clamp on either side, and you would drill through, and they would make it so that the screws would have to drill into a plate behind it, which isn't always convenient. And they've evolved to the point where now we're looking at the DePace-Synthes and the Zimmer Biomet systems, and these are the two dominant systems currently in place. The DePace-Synthes are nice with their matrix ribs in that they have these pre-molded titanium plates. They don't always match where the ribs fracture, so that kind of molding isn't always helpful, but it does help because they actually curve them in 3 dimensions. The Zimmer Biomet system is also extremely flexible. You have plates that come in a variety of sizes from short to long, and pre-curved and straight plates that you can kind of custom bend. So you can see in the kit that they give you, you have screws of all of these different lengths, and you have a system for bending and molding the plates where you can put on a guide, basically, that you can bend to whatever fracture that you've reduced, and then you can custom mold the plate to match whatever exactly is happening. And the other really nice thing about the Zimmer Biomet, and this is what we use here, is that the screws that they use are designed to be locking into bone. So if you get a bicorticate grab, you don't need to pre-drill. They're basically designed to drill through and grab the back end of the second cortical plate of a rib, and that makes it actually a very flexible and rapid system to use. The DePace-Synthes, even though they have better drills, you have to pre-drill the holes, and that's there's advantages and disadvantages to those threaded screws. The advantage of that type of screw is that you don't have to have perfect opposition to the plate. The screw will pull the plate against the bone, but at the same time you have to pre-drill, and that's just more work. The Zimmer system, you don't have to pre-drill, but if you don't have perfect opposition of the plate to the bone, you'll end up with gaps. So trade-off one way or the other, which pain you're more interested in dealing with. They're both very good systems. I've used both. We're now currently implementing the intrathoracic system. So this is new. This is RibFix. This isn't RibFix Blue. This is, I'm forgetting the brand name for it. But anyway, intrathoracic, this comes from the Zimmer Biomet folks. We're trialing it for the next year. And this is a system where you can actually do intrathoracic plating, which means that you can combine it with VATS, which is often very helpful in these patients who have retained hemothorax. So you can go in, suck out all the excess blood. You can avoid, as much cutting and exposure some of the time, and do relatively percutaneous. And I say relatively percutaneous because you still need to land the drill from the outside and guide these screw systems in. And in a bigger patient, to dig a deeper hole, you have to start with a wider cut. And so it's not always buying you a minimally invasive approach. This is more challenging in bigger patients, but there are biomechanical advantages to the system. One is that just purely from the point of view of like metal on metal, you're fixing screws to metal across bone, and they say that it has something like 400% more strength than the systems that just drill into bone in multiple places, because your screws basically are fixed directly into the metal across the bone. It has more stability. You only have to put 2 screws in, and it just happens that when you're using this system, because you stick the plate in the chest and you use these wires, you Seldinger wires in, and you pull it up against the chest, it tends to actually reduce the fractures really nicely without a whole lot of effort. And so you end up with a nicer reduction, which is one of the critical aspects of this. And I'll talk about it a little bit more in terms of indications when we need to do this. But the reduction is often the most important issue. It's not enough to just fix ribs to ribs. You need to reestablish the architecture of the chest for these folks that have had a significant injury. Oh, that's the brand name. It's the RibFix Advantage. Sorry. So in terms of the evidence, flail chest is currently the strongest indication. This is where we actually have evidence where you actually can improve mortality. So flail chests carry a mortality as high as 20%, and you can have it with rib fixation. So I think anytime you have specifically a physiologic flail, that's when you need to get in touch with one of us that does this. And one of us, I'd say in ACCS, the names to know are going to be me, Jen Leonard, Jason Snyder, Bracken Armstrong, Charlie Srivalasa. Who else does rib fixation? I think Mikhail does it. Doug Schur, of course, does it. It needs to get seen by one of us because, like, the people that do it will often be able to judge better whether or not we're going to do something that's actually going to help a patient. There's lots of factors that go into this, and I think that having just like a higher degree of alertness and just knowing that within the ACCS faculty to say, hey, maybe talk to one of the rib fixation folks. We all know who they are. They'll get the pictures in front of us, and there's almost always one of us on service or one of us around, and we'll take these cases on and take care of it. There is some data. It's technically, grade 1 data, but it's slight. That there's a benefit for decreased pain and improved pulmonary function for repair of greater than 3 successive rib fractures in a row without a flail. The data is from an RCT. It is, it ends up being kind of higher grade data than it deserves. It's actually better than what I listed here because there's been a subsequent RCT that's come out that shows that it can decrease it, but it's actually a quasi-subjective measure of return to function. I think the ultimate problem here is that we haven't been able to codify the indications well enough to capture who needs it. It still ends up being a little bit of a judgment call, and we will put them into some people who might have done well with or without it. But whenever it tries to be studied and you just try to come up with a hard and fast rule, we're capturing too many people. If you've done the procedure, what you'll find is that there will be people who are like in extreme pain, requiring a fair amount of narcotic pain medication, and you'll put these plates in, and the next day they don't care about the cut at all. The rib pain is gone, and they're like walking around the hospital. We had one patient who was, proselytizing, rib fracture repair, like walking around telling the nursing station, like, oh, this is great, this is amazing. There's people that are hugely helped by it, but the criteria that we've come up with to try to study in trials like successive rib fractures, et cetera, are a little too non-specific. So we're picking up a lot of people that maybe are not benefiting from it, and it's kind of weakening the data. But when you see the people that are greatly helped by it, you know that this is a therapy that, takes somebody that was on their way to getting intubated, and now they're walking around in the hallway saying that they feel great. And you're like, this did something. We just have to figure out a better way to capture the people that are going to benefit. There are some contraindications. Pulmonary contusion is a relative contraindication. I think if you have a pulmonary contusion and it's severe enough that you're going to get intubated no matter what, that takes away one of the metrics of success, which is avoiding intubation. I would say that if somebody has a pulmonary contusion but they still have significant disruption of the architecture of their chest, we're going to do it anyway because they need their chest architecture restored. But it's something to think about, that if somebody's going to be likely intubated for another reason, they might not benefit from having their ribs fixated if they're going to end up on the vent for 4 or 5 days anyway because their lung is so bruised. And the other one is a severe TBI, also not absolute. We should think about it hard. If these people are going to be intubated for days because of the TBI, they're probably, again, because positive pressure, this used to be how we would treat this problem. It does solve the problem. It keeps people expanded. The lung pushing against the chest allows it to heal. If someone's going to be intubated because of their TBI for a week and get trached anyway, probably not going to benefit from a rib fixation. So it's just something to think about. One of the other important things that we should be thinking about is the timing. We know that doing it earlier is better, so you can avoid some of these downstream complications such as pneumonia, tracheostomy, prolonged ICU stay. We know that doing it earlier is better. We don't know what the exact window is. You can show it's better to do it within 3 days or within 7 days. I think that the general point of the data is to say that the trend is towards doing this earlier. We don't know exactly how early, or if there's like a window that you miss. I've plated people beyond 7 days, but if you think that this is going to be a problem, it's better to get in touch with us sooner than later. The other preoperative planning, the antibiotics we use are the same for any skin cut. We're not dealing with bowel or anything like that, so ANSEF is appropriate. DVT prophylaxis, CT imaging is very helpful, and reconstruction in 3 dimensions. For some of us, we really like that. I think it's great when you can do it, and there's even if they haven't done it through radiology, there's basically apps that you can upload the DICOM images. Jordan Kirsch was very good at this, and make a 3D reconstruction on your own that you can rotate and kind of figure out how you're going to do the fix. The ribs that are beneficial to repair are the main breathing ribs. So fixing 1, 2, and 3, usually not hugely helpful. The ones that cover the majority of the surface area of the chest and are the ones that help you expand are going to be between 4 and 10. And the floating ribs are probably useless to repair unless they're puncturing something. There are also physical limitations of what we can fix. If you're fractured all along the spine and there's no place to land it, there's not a whole lot we can do. So if they're extremely posterior rib fractures, we need about 3 centimeters to get enough screws in to land them so that this will be a stable repair. So unfortunately, we really can't do anything about folks that fracture right along the spine. That's not usual. Usually people kind of fracture around their scapula or anteriorly. But when that does happen, what can you do? Fractures within 2.5 centimeters of costal cartilage. This is actually, from my point of view, fine, especially in older patients who have a lot of calcification in their costal cartilage. I fixed somebody recently that their costal cartilage was so calcified that it was just like bone and took screws great. So I would say that's a soft call. Generally, if there's a strong indication to repair somebody and they're broken near the costal cartilage, we can either go across the costal cartilage or we can extend onto the sternum if we need to, and that's what I did for this guy, and that is a reasonable option. But, somebody needs to be a little bit more experienced and comfortable with that.
Hey, Mark, sorry to interrupt. I have
Sure.
a question, Chris Holthouse. This was like a slide back, but I might have missed this. But on those ones where rib fractures on the vent, is it a thing for them? Like if it's really fragmented or not, is there benefit to stabilize that so it doesn't puncture lung? And if it didn't cause a pneumo, can it do that? Does it prevent it? Do those things happen or just not happen?
I think if they're going to cause the pneumo, they'll almost always do it before they're on positive pressure, because the positive pressure tends to reduce the ribs itself, and the lungs being expanded will push things out. There is a benefit to fixing people who are already ventilated, who you don't think you're going to be able to get off the vent. And you may be able to avoid a tracheostomy if the reason why they're on the vent is that they have significant rib fracture. So I don't think ventilation is a contraindication if they've already had to be intubated. But I don't think that they're going to go on to puncture their ribs if they're positive pressure and they haven't. Their lung, if they're on positive pressure and they haven't already done it. I just hadn't seen that. I'm sure it's one of the possible things. And once again, it's like I say, the issue always is the architecture of the chest. If they have like huge disruptions of the architecture of the chest, they will end up on positive pressure for weeks and trached and all that. And if we can avoid that, that's huge. And that's what I'm looking at is I'm looking at architecture.
Sounds good. Thank you.
No problem. So we have a lot of small trials and a few meta-analyses. One of them is actually from here in Washington University. Again, the major metrics we're looking at are shorter mechanical ventilation, shorter ICU stay, hospital length of stay, decreased mortality, certainly for flail. pneumonia, tracheostomy, we can decrease the risk of tracheostomy, but not totally avoid it. I mean, we're looking at a 0.25 percent relative risk. So a fair amount of folks are still going to end up needing a tracheostomy. And really, the strongest indication is flail. And I'll once again say that the flail has to be more than just a radiologic flail. I think you really got to look at physiologic flail. Because there's a lot of folks that have radiologic flail where, yeah, they've got ribs fractured in a whole lot of places, but if they're not significantly displaced or they're not truly bicorticate fractures, if the chest is still stable and things are in place, it's going to heal, and they may not benefit. We should still be, asked and take a look at it because there's also the pain control benefits. But the physiologic flail, so like if somebody's chest has got paradoxical movement, we should absolutely be doing this. Or if their sternum is having paradoxical movement, which I've seen more than a few times now, we should absolutely be fixing it because those folks are so unstable that that without some piece of metal putting things back in place, they're going to suffer and have a longer course. So again, SSRF for flail chest, that's surgical rib fixation, is strong. If you look at this forest plot, we can decrease duration of mechanical ventilation, we can decrease ICU length of stay, we can decrease mortality, and that's huge. Hard to show that signal for other things. Pneumonia, tracheostomy, etc. Non-flail, it's weaker, and again, I think the issue is that if you're just saying, more than 3 rib fractures or trying to measure displacement, you're not going to capture the kind of gestalt image of like, oh, this chest is not going to work, which is what we look at. We look at the patient, we look at the chest, and we're like, this person's going to fail, and that's who we need to figure out how to capture better and fix. The best data in terms of high quality evidence is it's pretty slight for greater than 3 rib fractures successively, is that maybe they require less pain medication, maybe they have a higher return to function sooner. Those are good things, but it's not the strongest of data so far. So in terms of the technique, one of the most interesting and fun things about this case is that the rib fractures, they never follow the same pattern, so there's some creativity involved in both the fixation and the approach. The exposures are interesting exposures for us, and they're worth learning for a number of reasons, because if you can learn these things, they can get you to places and teach you about anatomy that will allow you to address multiple problems, not just rib fracturing. So if there are anterior fractures, so I recently had a patient like this where I did an inframammary incision, supine position, did an infrapectus flap, lifted things up, put plates across, and was able to fix basically someone who completely dissociated the ribs from off of their sternum. That's kind of very classic. Most of us know that from thoracotomy. Similarly, with the lateral exposure along the border of the latissimus dorsi, one of the things I emphasize about this when I'm doing the cases is that the less you cut muscle fibers in half, the better functional outcome they're going to have. If you instead make an incision over the muscle and split them bluntly, you basically just can put a Kelly in, split the muscle fibers apart without breaking them, they're going to have a higher functional outcome. If you cut a muscle fiber, the best recovery you're going to get is 50% strength. So, and since this is a functional repair, we really want them to retain muscle strength afterwards. So muscle splitting incisions. And one of the great tricks is to use an Alexa wound protector. You can basically split the muscle with a Kelly, dive through, get onto the chest wall, and stick an Alexa wound protector in there and just kind of move it around, because it's like this kind of circular piece of plastic that opens up that space underneath, and you can move it around without dividing the muscle, and that will really help in terms of their pain and recovery. The most interesting one that I think comes up a lot and is a good technique to learn is the posterior exposure along the oscillatory triangle. So the oscillatory triangle, if you remember from medical school, is the thinnest part of the chest wall. It's just medial to the tip of the scapula, and it's just above the latissimus dorsi. It's just below the rhomboids and where the trap inserts in the scapula. And there's just this little triangle that you'll find when you cut into that that's just occupied by fat. And you can stick your finger directly down onto the chest wall, dissect around, go all the way up under the scapula, go all the way to the back, go all the way under the serratus plane. You stick a wound protector in there, and you can go all the way up to rib 4. You can go all the way down to about rib usually 7 or 8, and all with a really small incision without dividing muscle. So people will have very good functional recovery for posterior rib fractures if you know where that anatomy is. And like I say, minimal sparing splitting incisions. This kind of comes from our ortho colleagues and what they know in terms of generating functional recoveries. There's not great data on it, but I think it's pretty clear when they show you the pictures of even on case series of the difference between muscle splitting and muscle sparing. Like people have really significant loss of muscle mass when you divide it in half. Because some of those fibers are just never going to find their way home. So this picture I kind of include because I hate it, and this is kind of what I would say you don't do. So here's like a picture of the oscillatory triangle, and this is division of muscle fibers to get up and under things, and it's like I would absolutely not do this. If you go into the triangle, you can go and make a very small incision and avoid this large division of both the lat muscle and the trap muscle and rhomboids. This is like I include this almost just surgical horror. This is going to result in a bad outcome. It's going to be a really easy rib fixation if you create this enormous incision and divide all of this muscle, but you're not doing your patient any favors. But cutting the skin, the patients don't seem to mind the incision nearly as much, and they once the ribs are fixed, they're much happier folks. So they will not complain about a larger skin incision. And if the skin's what's holding you, it's okay to make that. But I'd say this is kind of like super old school. You don't need to have like this huge giant exposure. You experience a little bit more pain maybe through a smaller incision, but the patient will do a lot better for it. This is a picture of the kit. So this is the RibFix Blue. This is the kit we use here from Zimmer Biomet. And it's got all sorts of neat tools, and there's lots of flexibility that's included in this kit. So just to kind of go through some of the things that come into this for our surgical friends, we have the power drills. I don't know if you can see my cursor over here on the right. They have a right angle screwdriver that if we contact the rep ahead of time, he'll basically travel around with it and bring it to you if you give him enough warning. So you can do right angle drilling. It's like a dentist drill. So you can get into really tight spaces and drill down without having to do bigger incisions. So you don't have to drill down on things. You can actually approach things from underneath the incision and dive down. And it's worth reaching because the reps are very interested in helping us with this. I'm pretty sure that every time I bring them in for a consult, they're able to buy a new car given how expensive these plates are. But they will show up on a Saturday morning with their right angle drill to help you out, and it's worth doing. Here in the middle, there are a number of tools for intracorporeal bending, and so like even if you get a plate in and it's not quite perfect, you can grab the plate and you can bend it into position. You can put a few screws in, bend it to match things perfectly. And then I'll just point out right here, the caliper. It's important to measure your distances. If your screws go a little bit too long, you're not going to like get into like the heart or anything like that, but it is possible for the points to stick out a little bit, and they might cause some pulmonary lacerations. The difference of even a few millimeters might matter. So we're going to measure each one. This is the handheld right angle screwdriver. It's nice, but not nearly as fun as the power driver. So what are we talking about in terms of technique? The thing to emphasize in this technique is this is still a reduction. It's not just a matter of fixing the ribs in place. If you fix somebody who's bent in like this or like even like this, you're not giving them that full lung expansion. You need to fully reduce the rib back to a physiologic position and then plate across it. So they're showing a pair of what we would call lobster claws here. They look like penetrating towel clamps. There's ones that have teeth. I actually just use right angles and go over the top of the rib so that I don't risk banging up the intercostals and causing nerve and artery and vein injuries and things. So I grab the ribs from the top on either side with right angles, pull them up to bring them in appropriate opposition, and then put the plates across. These are what the plates look like. They have these, pre-cut holes that you put the screws through. The screws go through and they grab the front cortex and the posterior cortex of the rib and lock them in. You can contour the plates with various benders. This is the Zimmer Biomet fixer. You can bend them in multiple dimensions, so you can bend them to the contour of the rib. You can bend them to fit the curvatures of the ribs. You can bend them so that they curve as well. You can custom bend even a flat plate to fit any rib at any location. And the ribs have lots of different curvatures depending on where you are. Like posterior, they'll actually often make a pretty sharp turn, especially like in your COPD patients who have those barrel chests. And so not every curve is going to come out of the box just how you like it. You load the plate against the rib in close opposition, and then you put your drills through. Pre-drilling for the dipiosynthese and the Zimmer Biomet system, luckily, it drills through and it grabs on both sides. But again, like you have to have it in perfect reduction to start. You have to have at least 3 screws on either side of the rib to get adequate strength. More is probably better because a lot of times getting close to the fracture, the bone isn't as high a quality. So I try to do at least 3. If there's more room, I'll try to put in 4 or 5 just to make sure that you have a good fix. The same techniques apply to sternal. So we will fix sternums, and it's rare. We probably fix about 3% of all the sternal fractures that come in. Sternal fractures are otherwise stabilized in so many different dimensions that this doesn't come up that often. But if you have somebody that has a significant crush injury, and especially if their sternum is moving with breathing, it probably deserves to be fixed. And there's lots of custom plates that you can use. I actually often will just take 2 rib plates and put them down as like railroad strips on either side. The sternum's got a lot more kind of bumps and grooves and stuff like that, so you have to do a lot more custom curving. But this comes up too. So sternal plating is something also to think about in people that have fractures across the sternum, especially if they have a sternal tear, which does come up. Okay. In terms of technique, and this also figures into our selection criteria, whenever possible, it's good to stabilize both sides of it. But if somebody has a flail and they're have those posterior fractures, like I said, that were within 3 centimeters of the spine and you can't fix it, there's still a benefit. Because if you can fix one side, it's going to have increased stabilization. You're not going to have that physiologic flail. So even if you can't fix all of it, it's okay to fix one side, not the other. It's better to do both, of course. We can't fix gaps of greater than 1 centimeter, but except in the case of people that have big tissue loss that rarely comes up, and you can use bone grafting techniques in those cases to bridge gaps. You can use it commercially available graft, but also if you recruit your orthopedists, they can take out like the top of the ischium and stuff. They can grab you bone graft material to put in between. Routinely using thoracoscopy as part of this is not strongly evidence-based, but this is actually a great opportunity to fix 2 problems at once. If somebody needs to go for a VATS, we can do a VATS and rib plating at the same time. Especially in our trauma patients, early evacuation of hemothorax is a thing that should absolutely be considered. You don't want these people to develop rinds and trapped lungs. And chest tubes don't always have to go in, but I generally put them in because these people often have violations of their pleura, and they already have chest tubes in place. I'll usually take them out at the beginning of the case if they don't have a air leak, and then put in surgically placed ones at the end through clean incisions. That does also bring up another issue. If people have put chest tubes over the location of the fracture, it's not the end of the world. We will still go into that space even though it's kind of dirty. The plates rarely get infected, and even if they do develop an infection in that space, often we can drain it and then sterilize it. the titanium doesn't tend to generate biofilms. So I've actually had success in people that have had surgical site infections, draining it and cleaning it up and giving them several weeks of antibiotics, and then them being fine. The plates don't act as a persistent source. Risk factor modification to decrease the risk of non-union. So non-union, what is this? Sometimes people will heal chest fractures and they'll end up with a pathologic callus that isn't fully stable, or if they have a significant gap, the two ends will callus off and they'll have continual movement. Those folks, I consider it a chronic non-union if they have more than 3 months of healing and they still have either symptoms of movement of the rib, crepitus, you can feel it move, or they have CT evidence of a gap and pain. And I'll take them back and cut off the pathologic callus and then fix them at that time. It's a little bit more challenging in these folks because a lot of times the pathologic callus occupies a lot of space. And I haven't had to bone graft any of these folks yet, but it's gotten close. A lot of times you end up cutting back so much unhealthy bone that you're ending up with a more significant gap. And in those cases, you'll need to consider a bone graft. This is another indication to do it. So like if people have significant gaps to be reduced, preventing non-union is another goal of this procedure. I emphasize over and over, this is a functional repair. Our incisions do not need to be huge. We can go through small incisions if you're smart about planning them and know the anatomy of the chest. And
hopefully he pops right back up. While he's coming back on, just so you know, I posted a CME link and I posted the Heretic conference link in the chat. And we'll await Mark and see if he can come back on.
hey, sorry about that. My computer just conked out. I'm plugged back in. I'll bring us back up. Can I answer questions in the meantime while I'm bringing us back up?
We got you going again. Anyone have anything they want to ask in the moment?
Sorry about that. I thought an 80% battery would get me through the Zoom, but it just ate my laptop here. I saw a few questions in the chat, so let's see.
Those might be my links.
Oh, those are your links. Okay. Okay.
Yes.
I got my computer back up. Sure. Hold on a second. Let me get back to the Zoom. So all we have to do is cases, and then we're done listening to me talk.
Can you talk a little more about the bone graft, like where you would think it's safe to take it from, or how you, a little bit more about that technique?
Sure. So you can take them. Off of you can basically take chunks off of the pelvis, or sometimes they'll take them off of the costochondral margin, are like the two classic donor sites. If I think somebody is going to need a bone graft, I would typically reach out to the orthopedists who know the most about capturing that, and bring them in to provide it, because I'm not usually the one who's cutting down on the on the ischia to carve out the bone. But that's the two locations where you have plenty of material. It's not important in terms of weight bearing, and you can do autologous without loss of significant function. I would usually go for ischia, just because if you're fixing on the chest, you probably don't. If they already have a problem there, I'd rather go to like a purely healthy site. And
Recording in progress.
haha, we're back. Okay. To go to a completely separate site. Sorry for the technical failures. There we go. So I'd prefer to go to a fully healthy site like the ischia and have them help you with bone graft there. You can also get bone graft out of the blood bank. Essentially, they have non-autologous graft material that is that's available, just like cadaverous skin graft that you can put into place. But if there's an autologous option, I would generally presume that's better. There is not strong data on that, and the 1 centimeter gap at this point is still like a rule of thumb based on what we know from translation over from orthopedic procedures. Let's see. So let me get my slides back up here. All right, sorry about that. All right, so quickly just go through some cases. So case 1 is a 57-year-old who had a bicycle accident. He basically was mountain biking and he fell off a mountain. He was transferred for a combined ortho and chest wall fracture issues. He had a clavicle fracture in addition to his chest wall injuries. He had to have chest tubes placed for pneumothorax. And he really presented for pain. This was a highly functional 57-year-old avid biker, was just hurting a lot and was struggling basically to discharge and was requiring a high level of pain medication. So I offered him rib fixation. So this was what he looked like before. Hard to tell from a chest x-ray just how bad it was. Here's a video of his chest. So multiple fractures with some displacement. And I think the displacement is partially key. They're in a nice zone to approach through the posterior approach, and the location is right in the middle of the ribs, not close to the spine, not close to the costal cartilage. This guy's a great candidate in terms of the logistics. And given his history and that he was having severe pain, we offered it to him. We got a 3D reconstruction, another video here. This is what this looked like. And you can see the ribs at this point. This was from a later CT. That was like his initial CT, and this is a later CT. The ribs are slipping behind each other. And this is something that, like, I really feel like, these non-intubated people, sometimes their initial chest CT doesn't show where they're going to end up. And if you get a later CT and the ribs have gone like this behind each other, it hurts so much for them to expand. Those ribs are maybe never going to find their way home. So these are good people to fix, because this is that disruption of the architecture of the chest wall that I'm talking about. For them to develop a healthy callus with good opposition of rib ends and not lose chest volume and not have kind of chronic pain from those continuing to slide, I think is slim. So this was a matter of like, this guy doesn't fit like the classic criteria. He's not a flailed chest, and it's only a few ribs in a row, but active person, bad architecture, offered it to him. This is it in another dimension. So not going to be able to fix this rib fracture up on 2, maybe not even on 3, but 4, 5, and 6, certainly we can do something about that. So this is the post film. These are the plates in place. So we fixed, I think that's 1, 2, 3, 4, 5, and 6. Got a new chest tube in place. His lung looks maybe more expanded. He's got some contusion from it already. Chest tubes got removed. He was seen in clinic for follow-up, and he basically said he never had pain after the operation. After the operation, I actually went and saw him in the PACU, and he was complaining about his clavicle then. He's like, actually, my chest feels totally fine. Can you do something about my shoulder? And the orthos who, don't always manage clavicles with operative fixation ended up fixing him. And he did great. So there's he is with his clavicle fix too, as well as his rib fixation. In clinic, he was doing awesome. I feel like I got a little bit of costophrenic blunting here. He may have had a little bit of a retained hemothorax. But overall, good outcome. He was back on the bike. Here's case 2. This is a crush injury. So he fell off of a 7-foot ladder onto a solid object. He had an epidural, and so here's one of the things at WashU is we're very aggressive about epidurals. We have very good evidence that we can avoid a lot of complications from epidurals. But the sad part of it is that sometimes this is making it so that we're not seeing the people who need to be fixed when they need to be fixed because it's delaying kind of the presentation. The epidural works great, but eventually you have to turn it off, and those ribs hurt. I usually quote people about 6 to 8 weeks before they feel about 80%. Ribs hurt for a long time. So the epidural will cover the early, most acute phase of it. But when that epidural wears off, if they're just suffering and dying, maybe they need to kind of get a reevaluation. So we went and fixed a flail. Here's a video. So right-sided, multiple rib fractures. Look at how terrible those posterior fractures are, penetrating into the chest. Epidural was never going to solve this problem. That was going to hurt immediately once the epidural stopped because they have such disruption of the architecture of the chest. Another view. So yeah, that's that one rib. If I see something like this poking into the chest, it's like, even if this was a single rib, I think you should justify taking this person to the OR because that rib's never going to find its way home. This is a picture. This is what the reps will provide based on what you put in. So I fixed 5, 6, 7, 8, and not. Let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. So that was six successive ribs. This is the post picture. Nice recovery of architecture of the chest. So this is what you want to see, is that the chest is now nice and re-expanded. The ribs aren't poking in. This allows the lungs to fully re-expand. So he was extubated the next morning after this. He went to the SICU afterwards just because he was older and had issues. Post-op day 3. So I fixed him during the week, and then I was on call on Sunday, and I went in to see him, and he had been intubated and didn't remember any of it. So I woke up and he's like, the only thing that's bothering me right now is that I can't eat. So didn't mind that I had put an incision on the side of his chest. Wasn't feeling any rib pain at all, whereas before he was completely non-functional from these terrible fractures. And aside from developing an ileus, he did awesome. So this is another one of these people. He was remarkable to me because he's like, I literally have no pain. I'm just hungry. It's kind of astonishing knowing a lot of people and seeing a lot of folks with rib fractures. Rib fractures hurt like hell for a long time. So hearing somebody say that, it's like this makes this hugely rewarding cases. This is what his incisions look like. And that was the clinic picture. So good recovery, good chest architecture afterwards. All right, MVC sternal fixation. So this was a combined, I think. Did I do? Actually, no. This guy was really interesting. Sternal fixation is interesting case by case. Even though sternal fractions happen fairly often, very few end up needing to ever be fixed. However, it does come up. And there's a few really specific interesting cases where it comes up. One is sternal flail. The other is if they need a spine fixation at the same time and they need to go prone. Sometimes if you lay these folks prone, they will die because their sternum is no longer intact and protecting their heart. If you lay them prone and put their body weight against their heart, they will not be able to fill and they will code. So I've had to fix one person specifically for that instance where they had a significant spine fracture. We had to fix it. And then this patient actually was interesting because he had a really dramatic sternal flail. And I wish I actually had kept a video of the sternal flail, because that's how they consulted me. Is they sent me a video of his sternum going like this when he breathed. And they consulted me because they were concerned they were going to have to intubate him. And this was how severe his sternal fracture was. So again, I worry when the architecture is disrupted like this that the ends aren't going to find their way home. Sternums are different because we can't stick that caliper in there usually, so you need to measure the sternums ahead of time on the CT to know the thickness of the screws. And the sternum has variable thickness throughout its length, so you have to measure it in multiple places on the CT scan and add 2 millimeters for the plate. We fixed them with 2 Zimmer Biomet 12-hole screws, custom bending. This is what I mean by you need to put in more than 3 screws on a given side, because sometimes the bone is mediocre near the fracture. Those 2 that I put on the top, those aren't touching postcortical bone. And actually, I think I should have put in a 4th one on the top, because I probably only have anterior fixation on the top. But this guy did great. He was extubated the same day post-operatively. He was moved out relatively quickly, had a good IS, discharged at home day 9, seen in follow-up, no pain. And then lastly, chronic non-union. I have a better non-union I've done since this one. But this is what happens when people have those sliding ribs and they never get fixed. They end up with this non-functional callus. And the callus doesn't show up great on CTs. You can see some of it forming. But this patient presented with constant pain every single time he coughed. They were 3 months out from their injury, and they still hadn't had recovery. Small incision, took out the callus, put on rib fixes on the 2 ribs that were the most effective. Seen in 2 weeks, still had pain, better controlled. The chronic non-unions are tough. One of the issues is that folks that have had pain for this long will often end up with pain even after you operate on them. And it's really helpful to have them see the pain service beforehand, because you want to do 2 things. One is you want to make sure that there's going to be a resolution with the fixation itself. And if they get an intercostal nerve block and they feel better, it's a good sign that the pain is being caused by the fractures themselves and the hit to the intercostals. If they don't benefit from a nerve block, fixing the ribs probably isn't going to fix the problem. You can take out the movement, but it's not necessarily going to fix their healing. So these patients you have to approach very cautiously. And the second reason is that they often still have pain even after you fix them, and it never quite goes away, because once somebody's had that kind of nerve injury for weeks and weeks at a time, it doesn't just tend to go away immediately. So having them connected to the pain service and using other pain modalities, including multimodal pain relief, is a good idea to get started beforehand and afterwards. One of the things we're going to talk about with Dr. Bauman in a few weeks is talking about cryoablation for these folks, which is a technology I really want to bring in. And it gives you arguably somewhere between 8 weeks and 6 months of numbness, just to ablate the nerves and take them out of the picture. And for folks that have rib pain that maybe don't need a fix but are going to suffer for 6 weeks, that could be huge. And for these folks that have chronic nerve pain, it could be a way of basically hitting the reset button and getting them back to pain zero for a relatively long portion of time. And I look forward to hearing his talk about that and seeing where we are with implementing the technology here at Barnes. That's it. I went a little long, sorry for technical errors.
The response, but not. Okay, Elijah.
2 seconds. All right, guys. Just for the sake of time, are there any questions? If not, just for timing, I will say thank you, Mark. That was great review of it all. And thank you for doing this again. next month, please make sure just check the links in the chat for CME and for the Heretic Conference in Pitt. And next month, Holger Bauman will be on to talk about rib fractures from the anesthesia side.
And actually, hey, I'm Brandon Wojcik. I'm one of the fellows. Do you mind if I ask a quick question here?
Absolutely.
Quick? Sorry, I was trying to start, Dr. Hoofnagle. Sorry, I was catching this in between a bunch of traumas. But one question, because as far as patients and these indications, because speaking from a patient we have on the floor, I think a guy we saw Friday, but who has a flail on CT, but is like respiratory doing well, says that, I mean, is pulling over 1,000 on his IS, like not on oxygen. Well, I mean, one of my attendings in residency always told me, like, never, talk someone into this operation, even though I think this guy would be a great candidate. For people like that, I mean, do you just kind of let them heal? He's not feeling his ribs moving, anything like that? Because I don't want to go like hardcore talking this guy into an operation that might make him worse than he is now.
Yeah, like you can't improve good. If somebody's already cruising, you can't make it better. So there's radiologic flails where people have segments out of order, but the ribs are stabilized by the intercostal muscles. They're stabilized in anterior, posterior, up and down, yada yada. So they can have a technical flail where there's presence of fracture, but if they're not displaced and they're not moving a whole lot, they may not hurt a whole lot. So if you're pulling greater than 1,000 IS and you're not complaining about pain, yeah, I agree. I'm not going to help that person. So I would say that, yeah, you should keep on with the conservative management, unless, of course, it's just the epidural is hiding it from him. Does he have an epidural?
No, he does not.
He doesn't. So, like, to me, that person's already kind of graduated, right? Like, I can't fix good. I can only make it worse. And they'll tend to do great as long as, like I say, as long as there isn't significant architectural disruption and they've like lost lung volume and things like that.
Yeah. And kind of the last question, sorry, I know we're still over time, but which I experienced in residency was especially the self-drilling, self-tapping screws that you don't pre-drill. I had a lot, we had a lot like in a row where ribs would split, which I've never had happen with pre-drilled holes. Have you ran into that as like being a problem? I mean, because it kind of made the decision in my mind that I was always going to pre-drill unless there was significant evidence to the contrary. I don't know if you've had that happen or just experience with that.
That's a patient protoplasm problem. So especially with the older patients who have poorly corticated ribs and they're osteopenic and their rib quality isn't very great, if you start putting the non-pre-drilled screws in those folks, sometimes the ribs will just split to pieces. So that's actually the rib quality is a consideration, and the folks that have osteopenic ribs will not do great with those. Now, I don't think we necessarily carry DePasynthes here, but we can call those reps and bring them in if we thought that was like a special case. I think it's a slightly more expensive system. Doug doesn't love it, but that's a totally relevant point. You got to look at the quality of the bone that you're going into.
Okay. Awesome. Thanks so much.
You got it. All right. We good?
I think we're good.
All right.
Thank you, Mark.
Guys.
See you guys next month.